Hello, Prof. How are you?
Good, thanks. How are you?
Yes, I'm okay. Thanks for giving your valuable time.
You're welcome. Thanks for tuning in a few minutes early. Yeah, I've got to get to surgery a bit earlier than expected. So
Okay. So thank you very much. So we can start. Already I have introduced about you for last half an hour. I am speaking about you.
thank you very much. You're much too kind. Much
So,
too kind. Can you see my screen?
yes, I can see that.
Okay, so what I'm going to focus on today is to show a series of videos for some different operations for fecal incontinence. And we're going to start out with the basics, being a sphincter repair. Now, these are narrated, but I'll certainly answer all the questions after. So let's see how this goes. The narration should play. If it doesn't, I'll narrate them. Okay, maybe my fellow took off the narration. So you can read the history. This is a combined sphincter laceration and rectovaginal fistula. So what we're going to do here is a combination of a sphincter repair and a fistula repair, which will be a combination, therefore, of an overlap of the muscle, as well as, an overlap of the muscle, as well as an advancement flap of the mucosa and submucosa. You can see the thin anoperineal septum, essentially an absent muscle. The patient is in the prone jackknife position. So the vagina is towards the bottom of the screen and the coccyx is up here towards the top of the screen. And what we're showing here is how there's essentially absence of muscle with a fistula through it. I first start out prior to surgery, the patient has had a complete oral mechanical cathartic bowel preparation and oral antibiotics, plus we give intravenous parenteral antibiotics, all to try to limit the possibility of post-op infection. Then I infiltrate local anesthesia, which is a combination of 0.5% xylocaine and 0.25% marcaine with 1 to 400,000 units of epinephrine. That helps for some local hemostasis, although as you'll see, there really is no bleeding whatsoever in the scar, just nearby in the other tissue, but certainly the scar itself doesn't bleed. So I usually start laterally because that's safe. You can just see it. We develop it starting laterally and then working medially. And here we go, going up past the fistula. The medial part is always the most scarred. You can see it's essentially just fat there. As we come to the fistula, we grab the fistula, grasp it and retract it. And what we need to do is dissect way above all of the scar. I mean, we need to get way well above of the scar.
Prof, can I stop for 1 second, please?
Yeah, sure.
In your view option button on the top, there will be one option that optimize for video. Can you press that optimize for video so that jerk will not be there?
Okay.
On the option on the top, you will get.
Right, I did that. Let's see if it happens.
So yes, now please play. Now there will be no jerk. Thank you very much.
Okay, so now let's see if that helps. Is that any better?
Yes, it is better.
Good, thanks for that trick. So now what we're doing is finding the divided ends of the muscle, which always are going to be retracted laterally, and dissecting out the rectum from the vagina. Okay, so we're getting into soft areolar tissue, and it's very important to get this up into soft areolar tissue way above any scar. It's not going to be successful. So we separate two layers from the back of the anus. One is the internal sphincter, one is the external sphincter. So here are the ends of the external sphincter, and you can see they're retracted, not surprisingly, where the fistula is, right? So we're going ahead and dividing that out because we need to get nice length for overlap. So we're just going to use diathermy for this dissection. It's, I think, very helpful. You can see how we're getting now the left side. So the right side of the external sphincter has been dissected free. Now we're working on the left side. So I'm just going to let you watch this dissection for a moment. And I think the full bowel prep is very helpful. Now here's internal sphincter. So it's what I've just grasped there is the internal sphincter. And the internal sphincter is going to be separate from the external sphincter. That's retracted as well. Now we're going to go back to the vagina and core out the fistula because we're going to have to primarily close that area. So we're dissecting the back of the vagina, taking out the fistula. There you go. We're going to core out the fistula and primarily close that area. And I use absorbable sutures. I use a vicryl suture here to close the fistula, and I close it on the side between the vagina and the anus rather than in the vagina. Now, once the fistula has been imbricated, what I'll often do is a kind of perineoplasty next, but here we're just closing the fistula. A couple of layers there because what I want to do is make sure there's good separation. Now, once that's closed, I see which way the overlap seems to work better, left to right or right to left. It's a bit like going to the eye doctor when they keep asking you which one you think is better, but ultimately whichever one works better. We also core out the anal side, and then we do a levator muscle imbrication, followed by this imbrication of the internal anal sphincter, because the internal anal sphincter edges have retracted as well. So we're putting those back together to get them nice and snug. And you can see before we even get to the internal anal sphincter, before we even get to the external anal sphincter, we've taken care of the levator muscles, and we've taken care of the levator muscles and the internal sphincter both. So the external sphincter becomes the external sphincter is the icing on the cake, as it were. Okay, everything else is already repaired and closed, including that hole. So I believe in anatomic reconstruction. When I learned how to do the technique, it was an unblock repair of whatever could be found. But once I got into my own practice, I said it makes more sense to reconstruct physiologically, if you will, and therefore to separately imbricate the internal anal sphincter and overlap the external anal sphincter. It gives more layers of bulk, and it reconstructs the way life started before the injury. And you can see how snug the anal canal is before we even do the external overlap. That's what I mean by the icing on the cake. We've done a levator muscle imbrication. We've done an internal anal sphincter muscle imbrication. Now, with the anus already tight, now we're going to start the external sphincter repair. And the way the external sphincter repair works is I take bites very deep on the patient's right, and I go kind of superficial on the left, and vice versa. These are horizontal mattress sutures of vicryl, and I want to make sure that I'm using the scar. I don't excise the scar. Gynecologists tend to excise the scar. I use the scar. I think it's very good to hold the sutures to allow them to really hold into place. Otherwise, if you excise the scar, you've made the muscle shorter. The halves of the muscle are shorter, and you're putting more tension on the halves of the muscle trying to pull them together. Whereas you maintain the scar, it's kind of like a pledget almost. It's like a pledget because it lets you very capably hold those sutures and you don't lose any length. So here you can see, again, these horizontal matches. So it's from lateral to medial deep on the right, medial to lateral, and then back lateral to medial on the left, and then back through medial to lateral here on the right. And you'll see what that does with these horizontal matches. So I lay in 4 sutures, okay, 2 from deep right to superficial left, 2 from deep left to superficial right. Once all 4 sutures are in, then I tie them. Occasionally I supplement with another stitch or 2, but it's very hard to put in the stitches if you started to tie them. So you tie them all at the end. Now what we've done with this reconstruction is we have kind of a 3-dimensional reconstructed cube, and I tend to describe it as the number of centimeters that we've overlapped, the number of centimeters of anoperineal separation, and the height. So it's a cube, height, depth, and width. I do not fully close the wound. I close the edges, but I leave the central part open for drainage to try to prevent or at least minimize the occurrence of post-op sepsis, because again, there was nothing here. This was a very thin anoperineal septum. Now it's a tight anal canal with a reconstruction. I used to use a bowel confinement regimen, but we published a randomized controlled trial showing that it wasn't of any value. I use perioperative antibiotics, and I send the patients home with just local wound care and oral antibiotics. So that's the simplest of the procedures. Now we get to the one that I think is the most common in this day and age, more than a sphincter repair, because it doesn't hurt and it doesn't get infected the same way in the perineum, and that is sacral nerve stimulation, which has been around for decades in the urology world, but was adapted by us in the 1990s in a trial, which ultimately I presented as the lead author. I presented it at the American Society of Colorectal Surgeons. We published it in Annals of Surgery, and it was FDA approved in 2011. So the patient is in the prone position, though not prone jackknife. We mark out the medial edges of the sacral foramina on the left and on the right, because we always want to be prepared to go on both sides. So you can see where the line is lining up, being marked. And then we go across the ischial tuberosities, as is shown here in the lower left. And we mark out our entry point. We infiltrate. So the patient is awake. Very important the patient's awake, because we're going to be asking them if they feel anything in the perineum, vagina, anus, any tapping or warmth or other sensation as we test. We want the needle going into the medial most portion of the sacral foramen, the 3rd sacral foramen. And it doesn't matter left or right. And quite honestly, I try to, unless I get a tremendous response on one side, I always try to have both sides tested, and I see which one is better. So you can see what's supposed to happen. And this is an older device. They're now wireless and kind of like an iPhone thing. So once the needle is in and we get a good response in the 3rd sacral foramen, we do a lead placement. So we put in this little guide wire under direct vision and cut around the needle. It's important to cut now rather than later, because if you cut later with the electrode in, you might potentially cut the electrode. So once we have a big enough hole, I put in the stylet, and you can see on the X-ray, this little bead here. We want about 2/3 the way from posterior to anterior and sacral cortex. And then we go ahead and put in the lead. And it's under fluoroscopic guidance. And we test each lead. So the leads are labeled 0, 1, 2, 3, and 4. What we want to see is the toe. What we don't want to see is the ankle turn in. That's S2. What we also want to see is a bellows response, where the levator muscles and the pelvic floor moves with that response. And we may be showing that here, a little bellows response. And then we have to tunnel the lead to a pocket on the other side for a temporary connector. So you see what I mean? I made this incision earlier. I don't want to make it now because I might injure the lead. So we tunnel, and you see I've got this sharp tunneling device going in the same little hole through which the lead is. And I think it's important to get some good distance between the entry site and the connector to try to minimize the infection. Although these patients don't get infection the way sacral nerve patients get infection, the Achilles heel of this operation is indeed infection because you're implanting a foreign body. So there you can see doing the temporary connector. And again, the device has changed slightly since I made this video. There's some differences. There's MRI compatibility and rechargeable, and there's even competition on the market with another company. So there's a variety of things that can be done here differently. So I tunnel the lead, it goes to a temporary connector, and that temporary connector is going to be in the pocket in which the battery, the stimulator, will be placed in 2 weeks, assuming the patient has a 50% or better improvement in their incontinence score. So we get their incontinence score as a baseline, and then we redo it. The wounds are closed, and then this temporary apparatus is put together, and then we do programming. Assuming the patient has a 50% or greater reduction in the incontinence score or the number of accidents, 2 weeks later, we come back, we take everything down, open this pocket to take out the temporary connector, and that allows us to put in the stimulator. And again, the stimulator has changed over time so that there are now options that are rechargeable, that are MRI compatible. The technology has definitely improved, and the batteries last longer too. So there's been some significant changes here, but you'll see how we assemble it. Okay, and then you put the writing going up. That's important. And the other important thing is to put the lead under the stimulator, because when you go back at a subsequent time to change it, you don't want to be in a situation where you make your incision and cut the lead. So the lead is protected by being under the stimulator. So that one is sacral nerve stimulation. The next one that I'm going to show you is a procedure, unfortunately, we don't currently have, but we did for a long time, which is artificial bowel sphincter, and I think it's a great option. Currently, it's not available, and it's a good option when somebody has complete absence of muscle, because sacral nerve stimulation works really well when there is muscle, even if the muscle is disrupted, even if there's a defect in the muscle. We've learned that we can do an SNS procedure with good expectation of success, even if somebody has a defect up to 180 degrees. But beyond 180 degrees, we need something else. And that something else used to be an artificial bowel sphincter. And I'm hoping that it again comes on the market. The way the device works is the cuff goes around the anus, the reservoir is filled with fluid, and the patient pumps this little pump, which goes in the labus majorum or the scrotum, as is shown here. And every time they pump it, half cc of fluid exits the cuff. Each time they pump, it empties. So half cc empties and goes into the reservoir, and then over the next few minutes, it refills. It's done in the it's done in the supine modified lithotomy position. Again, like the sphincter repair, a complete oral mechanical cathartic oral antibiotic and IV parenteral antibiotic bowel preparation. And the incision is made anteriorly. And again, like sacral nerve stimulation, this has to be a meticulously sterile procedure. We are implanting foreign devices. And the problem is, in some operating rooms, the staff kind of regard this procedure as just another anorectal procedure like hemorrhoids or fistula, and they're not perhaps as meticulous with sterile technique as they should be. And really, this has to be viewed like a an orthopedic operation with an implant being performed, and it has to be therefore very, very meticulous sterile technique maintained at all times. The incision is made as high as possible, really above the levators. You want to get this device seated up by the coccyx and the levator muscles. If it's more distal, it has a higher probability of eroding. So as soon as we are able to tunnel around, essentially it's either the apex of the anovaginal septum or high up on the prostate at the levator. So we keep dissecting. We want to be in soft, like the sphincter repair, we want soft, supple, areolar tissue. We have to completely isolate the anal canal, the distal rectum, so we can encircle it as we're doing here. Now, if you perforate the rectum, which can happen, obviously you can't put in the device. You have to wait some other time, and the patient may even need to be diverted if they become septic. But in the meantime, there's a totally separate team. There's a two-team procedure. So one team is working below. Here, once we have the tunnel made, we're measuring what size cuff we need, 13. And then the second team is going to prepare that cuff above. So it's a totally separate field. You don't want that sterile field with the cuff being contaminated by dissecting around the anus. In the meantime, there's a team on the top field that's developing through a suprapubic incision a little pocket in the space of retzius in which the balloon is going to be housed, the reservoir is going to be housed, and on top of that, there's going to be a tunnel made into either the scrotum or the labus majorum to place the pump. So now we have from the top field sterile. The balloon is filled. We have the size cuff we need, so we wrap it around. And it ultimately will lock by pulling it through. And we use these shod clamps, 2 or 3 shod clamps, to be sure we don't get any air in the tubing or the reservoir or the cuff, because if we get air, it will get an air lock and it won't work. Here's what I'm saying. You see how much tissue is distal? A lot of tissue distal to that cuff. We want it as high as possible. Otherwise, another problem with his operation is the cuff can extrude. It can basically be spit out through the anal incision. So we want to be sure that it's nice and high up. Now, here, this is showing the top team. So they're making an incision into the space of retzius, and that's the perineal field down below. It's on the left-hand side here, and you can see at the moment this tubing is sitting here. But once that space is made, we're getting through the rectus fascia, we're going to pass and tunnel. So we can get the, here's the tunneler, because we have to connect the 2 fields, right? We have to actually connect 3 fields, because we have to connect the perineal field, the pump in the scrotum or the labus majorum, and the reservoir in the space of retzius. Okay, so now there's little connectors, and again, very important to make sure there's no air. Okay, so this is just assembling all the device. You see how meticulous we are with these clamps. And it's really unfortunate that we don't have this procedure at present, because it is such a good operation for people with absence of tissue. And the results were really quite robust. And again, Professor Mishra asked me to focus on technique rather than on results, but they certainly speak for themselves in the literature. So these are Hager dilators. And what we're doing here is we've got to get that pump in place. I've alluded to it a few times already. And that's done with a series of increasing size Hager dilators from the abdominal field down into either the scrotum or the labus majorum, because it has to be in a place where the patient can easily feel it. and be able to use it. So this is labus majorum. So we have a nice big tunnel. We slide the device in, and it's very important that the patient can feel there's a little button there, which is a lock. And it's very important that they be able to feel that lock. You can almost see it, but they have to be able to feel that lock so they can work with it and pump it. Like I say, each time they pump, it's half cc. So usually the device holds 6 to 8 cc's. So 12 to 16 times they have to squeeze it gently to empty. Now we're closing the incision very carefully. You don't want to get a needle into that cuff, because if you poke it, obviously the whole operation has to be redone. Here we're just topping off a little fluid to be sure there's no air, but we're showing that there's no air bubbles. Irrigating wounds carefully. Okay, and these are these little connectors we use. What these are, they're like grommets or connectors like you'd use in, from a hardware store and other things. Right, except they're obviously medical grade, meant for this very small device. So these are all connecting. It's a very ingenious device, I must say. I have no conflict of interest whatsoever with the device financially, but I just think it's very clever. So at the end of the day, we're left with this incision. You can no longer see the cuff. It's been buried, but we're adding some things. Here's a little crimping device to get the tubing put together. And we leave the device deactivated at first just to let it kind of settle in. So we empty the cuff. Then once all the incisions are healed, often I used to wait about 6 weeks. And then we just pop that little lock button that I was talking about. So you can see it right here. It's a little bit of a bulge there. So here's where the patient pushes, what I was just showing, and then there's a lock. So we leave it locked and off for a while, closing the perineal wound, closing the abdominal wound. Any perineal wound I try to use interrupted sutures that I have to be removed long-term, like nylon. I think that's better than absorbable, just because they stay longer. They irritate the patient a little, but they stay longer. So that's what it looks like at the end of the day, and the bladder catheter is maintained. Lastly, I'll show you an operation that we still can do, which is a gracilloplasty. So we start out harvesting the gracilis muscle. The neurovascular pedicle is always 4-finger breaths past the anterior superior iliac spine. I use a nerve stimulator to verify that that's the muscle, and I then palpate. So there's 2 incisions in the thigh, each about 3 or 4 centimeters long, one over the neurovascular pedicle, then the second one distally over the tendon. So we isolate the tendon where we have the pes anserinus, if you remember from medical school and anatomy. The pes anserinus, we encircle the muscle, and I always put a couple of sutures, ethibond sutures, in that tendon when I divide it, in case it's the wrong tendon. It's possible that you can harvest the sartorius and not know it. So shouldn't happen, but it can happen. So having those sutures in allows you to do a tendon repair if you need to, and you have to be prepared to do that repair in case. So we're isolating the tendon as much as possible. And we're then going to put in these ethibond sutures, and I do a modified Bonnell stitch, which is a tendon repair stitch, in case I need to go and repair that tendon, reattach it. The gracilis muscle is unique because it has a single neurovascular pedicle, which is proximal. It has a large axis of rotation. So here you can see that neurovascular pedicle being stimulated, and you can see the muscle distally. Once that's done, I make incisions around the anus, and you can do this either in this position, or you can go into prone jackknife position. I think this position is better for fecal incontinence. I think prone jackknife is better for fistulas. So what I'm showing there is what I'm going to do with the muscle is wrap it either epsilon or gamma or alpha, depending which way I wrap it. But I want to tunnel it. And I also was putting in anchoring sutures into the ischial tuberosity because the way that tendon is going to be held is in the ischial tuberosity. So I take the muscle, which has been disconnected distally. It's been dissected to the neurovascular pedicle. I pull it through the ipsilateral incision. And I was showing you a moment ago with my finger, deciding which way it would wrap best. And it seems to wrap best from left to right posterior, then up anterior, then from anterior, from right to left across. And then we anchor in these sutures. So you can do a wrap that's 270 degrees, or you can do essentially 450 degrees. It's hard to do exactly 360 because the way it lies. So this wrap is 270 because you can see I didn't complete the circle, but that's how much length I had. Once the muscle is anchored in, we close the incisions, and I always leave two drains, one in the area around the anus and the other one in the thigh. I used to keep patients in bed for a few days in adduction splints, but we did a study looking back at multivariate analysis and risk factors for failure, and prolonged bed rest was really the only one we found. So I no longer keep them in adduction pillows. So I think that was the last video I put in today. I have 4 different techniques for fecal incontinence. Hopefully some new information for you, and I'm certainly happy to answer any questions anyone may have.
So anybody has any question? Regarding the different techniques of management of fecal incontinence? So, Prof, I think there is no question. All of they are mesmerized seeing all the recent techniques. And we hope that we can also start some of them, because, you know, the devices which you have described, it is right now not available in India, but in the future, maybe it will be available. So
I think the sacral nerve stimulation will probably be available in the not too distant future, but the sphincter repair and the gracilis are available because they don't require any devices.
right.
Now, the only thing I'll caution you about the gracilis, which I didn't mention, is all patients are diverted. I would not do that operation with that extent of dissection around the anus in a patient who's having bowel movement. So they have to have a preliminary defunctioning stoma, and then I close the stoma. Once in a while, I'm not happy with the anal closure, and the patient learns to essentially pull their knees together. Like I tell them, like, pretend you're holding a piece of paper between your knees, squeeze your knees. That's how the gracilis muscle activates, and they can learn that. And I ask them at home, give yourself a little enema, not with the phosphate because it's irritating, but just empty the enema bottle, use water, give yourself a little enema, and see how you do walking around the house. If they can hold that enema, I'm fine to close the stoma. But if they're having trouble, I will sometimes do the contralateral muscle.
Right, yes. So thank you very much for sparing your valuable time, and wish you see the again next time in Dubai, just in few days.
When is that one?
It is on I think 28th of the
28th. Okay, so so 2 weeks. Okay,
yes.
or next week. Okay.
Thank you very much. Thank you.
All right, send me a reminder. Thank you. Bye.